Medical news from JAMA Cardiology. 25-year follow-up of quantified mitral regurgitation. The study shows that in patients who feel well but have degenerative mitral regurgitation, MR, the size of the leak measured by effective regurgitant orifice area, ERO, predicts long-term survival, and those with an ERO in the upper moderate range, 30 to 39 mm superscript 2, gain a clear survival advantage when they eventually undergo mitral valve surgery. This finding challenges the prevailing practice of reserving operative referral for only severe, symptomatic disease and suggests that earlier surgical intervention may be warranted for a subset of asymptomatic individuals. Mitral regurgitation is one of the most common valvular lesions worldwide, and its prevalence rises steeply with age. While guidelines already endorse surgery for severe, symptomatic MR, the optimal timing for asymptomatic patients with moderate disease remains controversial because the natural history of moderate MR is poorly defined. Existing data have been limited to short-term follow-up or retrospective series, leaving clinicians uncertain whether a watch-and-wait approach truly protects patients from premature death. To address this gap, investigators conducted a prospective cohort study at the Mayo Clinic, enrolling 449 consecutive adults with holosystolic degenerative MR who were asymptomatic at presentation between January 1991 and November 2000. Baseline MR severity was quantified using ERO, a continuous, echocardiographically derived metric that reflects the true anatomic size of the regurgitant orifice. Patients were managed medically unless they later met criteria for surgery, allowing the researchers to capture both the natural course under conservative therapy and outcomes after operative correction. Follow-up extended through May 2025, yielding a median duration of 26 years, interquartile range 14 to 29 years, and a maximum of 34 years. The cohort was 62% male, with a mean age of 64 plus or minus 14 years. At enrollment, 127 patients, 28%, had an ERO less than 20 mm superscript 2, 128, 28%, fell in the 20 to 39 mm superscript 2 range, and 194, 43%, had an ERO greater than or equal to 40 mm superscript 2. During the observation period, 254 participants, 57%, proceeded to mitral valve surgery. The cumulative incidence of operation at 10 years differed dramatically by baseline ERO, 18% for ERO less than 20 mm superscript 2, 64% for 20 to 39 mm superscript 2, and 88% for greater than or equal to 40 mm superscript 2. In the medically managed subgroup, 5-year survival declined stepwise with increasing ERO, 88% for the smallest orifice, 72% for the middle tier, and 55% for the largest, p equals 0.01. When ERO was treated as a continuous variable, each interquartile range increase was associated with a 2.53-fold higher hazard of death after adjusting for traditional cardiovascular risk factors, 95% CI 1.30 to 4.93, p equals 0.01. Importantly, the benefit of surgery was not uniform across the spectrum. An interaction analysis demonstrated that the survival gap between operated and non-operated patients widened with larger ERO values. Chi superscript 2 equals 8.4, interaction p equals 0.04, becoming statistically significant once the baseline ERO exceeded roughly 30 mm superscript 2. Subgroup exploration highlighted that patients whose baseline ERO lay between 30 and 39 mm superscript 2, traditionally classified as upper moderate MR, experienced a pronounced survival advantage after surgery compared with those who remained on medical therapy alone. Although the abstract does not provide exact hazard ratios for this subgroup, the interaction term indicates that the operative benefit emerges precisely at this threshold, reinforcing the notion that moderate MR is not a homogeneous entity. These results have immediate implications for. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.